risk algorithm questions. And I believe everyone can see my screen. So as Heather said, we're going to go over a few things. First will be the PVP customization, and we'll talk about RAF gaps. And finally, the risk algorithm. And then again, hopefully we'll get through everything and have time for questions at the end. And I'll just say a bit about myself since I'm probably a new face for you all. I am newer to Azara. I came from Eye to Eye, which we were competitors and now we've merged. So I have been spending my time learning drives, but I think a lot of the concepts between the tools that I was most familiar with and Azara drives are very similar. My background also is nursing, and I was a quality director at an FQHC in Pennsylvania. And so hopefully I can put myself in your shoes in a lot of these situations. So in terms of customizing the PVP, this is functionality that has been requested from Azara for quite some time. The beauty of the PVP or the patient visit planning report is that it's a way for you to see what is open for your patients, access some quick information about them that can help you better care for them. Um, this slide says more care to deliver less time, and that's really kind of the crux of the issue. We don't have time to be scrubbing charts to see what is due for our patients. We need easy access to that information at the point of care. So again, your PVP is a quick, convenient, efficient way to get this done. I'm gonna pop over to the I'm gonna pop over to my other screen. Let me just stop sharing. Okay, and then I'm gonna go to my drives demo. Whoops. Added everybody, and then I lost it. Okay, so there we go. I think one of the best ways to get more involved in the trainings and learn the concepts is to follow along. I am in our demo environment, so none of this is real patient info, so we're not violating any privacy rules. But how we're going to do this is when you log into Drives, you will come to your home screen. Typically, you would go on the left nav, you'd go to the PVP area to run your PVP. But if you have admin permissions in Drives, what we're actually going to do instead is we're going to come to this admin button at the bottom of your left nav. When I get here, I'm going to look for the admin for patient visit planning, which is right here. And when I click on that, it's going to take me into our PVP admin, where I can see any of the PVP layouts that have already been created. Or up here in the top right-hand corner, I can see create a PVP layout. Let me just note that typically you're always going to have this default PVP. So if you don't have a custom one set up, you're going to see that PVP default. At the end of each row, you have a little gear. When you click on that, it gives you some options. For your default, you're only going to have view or copy. But for any other ones, you're going to have many more options. And we'll go through what these all are in a minute. It's always good to start with something that already exists. But for the sake of demonstration, I'm going to create one from scratch using this Create PVP Layout button up in the top. When I do that, it's in essence copying the default that you have, but also note that you have customization options starting over in the top left-hand corner. Again, you always have your info snippet. This is not super informative here. It's telling you you're in the PvP admin. Your layout name is going to be something specific to either the group of people that are going to be using it or the purpose of this PvP report. I'm going to call this one training, and I'm just going to say it's demo of functionality. Show in PvP. Once we create this and go back to the PvP, you're going to notice that there is a little drop-down menu in the top right-hand corner. So this will allow you to say, do I want this to be in the available selection for the PvP options? So I'm going to set that to yes. I could also set this to default if I want to. For now, I'm going to leave it on no, but what happens when you set it to default is that this does become the default layout for anybody coming in to the PvP area. Now I'm going to move over to the top of the screen on the right side. These are the demographic information areas that show up in the blue bar at the top of the PvP when you run it. Sometimes this is overwhelming. Sometimes people want more information. So again, at your individual centers, determine what information you want to see, and then you can use the little pencils to update that information or change it. So for example, I would like to have the patient's email address. I'm going to move that over so it's going to show up here. I also want to move it up above the gestational weeks. So I'm going to click the arrows here to move those things around. Similarly, in column 2, for example, we're not needing to collect gender identity or sexual orientation anymore. So what I can do is I can select that and I can click that left arrow to get it out of there, or I can double click it and it disappears. And then I'll hit confirm. Similarly, for this column, let's just say I want the RAF score. I'm going to click other and then double click it to put it in the selected. So that's pretty straightforward. That's going to be your demographic information at the top of the screen. Now we're going to move over to this section called sections. And you'll notice that alerts has a little padlock on it, meaning you do need to keep alerts on the PvP. But for example, we want to use this at the point of care for gaps and other types of information that, we don't want the providers to double order referrals, for example. So we can begin to add in information that we think will be useful. So if I check open referrals and you have the Drives referral module enabled, you would begin to see those sections appearing. The other thing you can do is as you are adding, and let me take this one off. So I don't want risk factors there. I'm going to take that one off because I actually want to add the RAF gap details. And again, we're going to talk about RAF today. So I'm going to add that one. Then what is nice is you can also rearrange these sections. So one way that I've seen people arrange this is keeping the things that are actionable on the right, perhaps, and keeping things that are informational on the left. So I'm going to put my open referrals over here. Now my alerts are showing on the right side. The diagnoses are now on the bottom left, and then the RAF gap details will be on the bottom right. So again, actionable information on one side, and then your good to know information on the other side. Are there any questions about what any of these sections mean or any of the demographic information for the columns at the top before I save this? Okay.
I don't see any questions in chat.
Okay. Thank you, Heather. So you have your save button in the top right. When you like what you've done, you can click save. You can always come back and change it later. So now I'm going to show you what happens. Here is our training PVP layout. You can see it is set to display, and we're going to go look at that. It's not going to be the default, and it shows you who created it and when. And before we leave, we'll come back to this gear. When you click on view, that's going to take you to the PVP area and open this up. Edit means I want to go back in there and make some additional changes. Copy is like a save as feature. So I like what I did, but I want to change it a little bit for another purpose. You can set the default as well. Change history is going to show you any changes that have been made. And of course, delete will erase that PVP layout. So because I'm here, I'm just going to click view. And what it's going to do is it's taking me to the patient visit planning report, and it's going to run the default filter that was set. When I come over here, it's already selected the layout that I just created. And so when I click on a given provider's appointments, I can see what I have created with, this is demo patients, obviously, but you would be able to see it with real patient data and start to think about, is this what I want? Let's pilot this. Let's show this to our quality committee or your clinical committee and get feedback on it. Any questions? Okay, let me just make sure that okay, great. While I'm still in the demo environment, I'm going to show you how you can then set this as your own default on your homepage. So the little lowercase green A, white A in a green circle rather, up on the top left-hand corner of your left nav. Typically when you click on this, you are going to be brought to some sort of scorecard and some sort of information about that your center wants you to see. If I am a person who typically works at the point of care, like I'm a nurse by training, or maybe I'm a medical assistant, and I don't want to stop here, I want to go right to my PVP. What you can do is you can come to your initials in the top right-hand corner. You're going to come here to Preferences. When I click on this, on the top section, it says My Home Screen, and it allows you to select either the default that was set for your organization by your drives administrator, a scorecard, a dashboard, or the PVP. So I'm going to select PVP, and then I'm going to click Confirm. So now my PVP will open up right when I log into Drives, but you see that there's nothing here. I can also set a default that will run when I log into Drives. In addition to taking me right to the PVP, it's going to run that specific filter for me. That involves setting a default. So I'm going to say I would like to I would like to look at tomorrow, and I have a provider already set up for active PCPs. So I'm going to select that as my rendering provider filter. And I can run this and see, is this exactly what I want, or do I need to make any changes to it? Then what I can do is I can add a new filter. I'm going to call this tomorrow active PCPs. I'm just going to save this for myself. If you're an administrator, you may have the ability to save this filter and share it across your organization, but I'm just going to keep it for me. I'm going to click save. Then, if I click on that little three-dot menu right at the end of the filter, I have an option to share. I have an option to set as default for me, or I have the option to delete. So if I set this as the default for me, and you can see if you hover over the info snippet, it's saying this will set it as your personal default filter. I'm going to do that. And then, for example, let me just go somewhere else. Oops.
Hannah, I'm, does everybody else still see her screen? Was that a yes, Martha? Okay.
Yes.
For some reason, I'm not. So, okay. I wanted to make sure
Okay.
everybody was. Thank you.
Thanks, Lewin. All right, so I've come somewhere else, totally different. Now what I'm going to do is I'm going to click on the A button to take me to my PVP. I didn't touch anything. You see my hands? I didn't do anything. It's run my PVP for me. And again, it has run this default PVP, or excuse me, but I can just quickly change that. And now I have the PVP layout that we set up. Questions? Can I do any of this another time for you? I do have slides as well that we're going to share.
Hannah, this is Maria from Community Care. Can you show them, and I thought this was really intuitive to be able to put this on the PVP, but can you show them how to like put that no-show the patient no-show rate? I thought that was really interesting because now on those PVPs that your clinical staff are doing, you can actually see like, is the patient going to come in today? There's a 40% chance that they're, but it's very interesting to me. So if you have a policy that discharges patients because of no-shows, you might be able to discuss this with your patients. But I thought it was a great option.
Absolutely. Yeah. So as Maria said, there is a no-show rate. And when I come in here, it's already defaulted me to this demographic category. And right here, I see this appointment no-show rate. So I'm going to double click it and I'm going to add it to my selected. And again, I'm in column 2, which you can tell because, oh, sorry. At the top of the box here, it's telling you where you are. And then when I do that, you can see it shows up here. So and I hope this works, again, this is demo data. If I save that, and again, right from here, I'm just going to click view. We'll give it a minute. So this first patient, their appointment no-show rate is 100, which is kind of crazy. This person has a no-show rate of 0. So maybe that's possible. Again, this person doesn't have a no-show rate, so maybe they haven't yet had an appointment to no-show. So that's kind of a few of the examples you'll see when you use that appointment no-show rate demographic information. Questions on that?
When they're looking at that no-show rate, what is the look back period on that?
I don't know that, but we can find out.
Okay.
And I'm going to guess, Hannah, that it's probably in the last year, but we can find out for sure.
Yeah, that's a reasonable guess.
It's either 6 months or a year. We use a missed appointment, but I think it's a year.
Okay.
And so they, in order to accurately use that, everybody needs to make sure that they have their, whatever is marked in their EHR as a no-show is what is mapped in Azara for a no-show or a missed appointment.
Yes. Mm-hmm.
Okay. And so you'll need to check your mapping and see what you have mapped to which appointment status you have mapped to from your EHR to what appointment status you have in Azara. Oh, and you're going to show it to us. That's awesome.
I think I know where it is.
I get lost in here real easy
There you
too.
go. I have changed this mapping category to appointment status. And again, you would just take a look. We have one thing mapped to no show. This again is demo data, so it's all very nice and well. You may have something that does not say no show or says it in a different way, but then just make sure that that is mapped to the drives value called no show. And you see there are so many different things that you could select in drives for your appointment statuses. So just be aware of that.
I think it also has to do with some of your workflows. And if your front desk staff or whoever's doing the appointments, if they take that appointment and they automatically reschedule it, it's going to show up as a reschedule instead of a no-show. Like if they call later in the day or something like that. So just making sure that people have that correct workflow will also make a difference.
100%. And make sure everyone's following the same workflow and things mean the same thing to people. You'd be surprised what, you think a no-show is a no-show, and then you find out somebody else is, like Luann said, leaving it on the schedule, and then because the patient calls later, they reschedule it, and you're like, but that isn't, they already no-showed the appointment, so that shouldn't be a reschedule. What else before we move on to our RAF gaps?
I don't see anything in chat, but anything pops up, I will let you know.
Okay. Thank you. All right, let me switch back to my slides. Okay. And I'm going to skip ahead to RAF gaps. Oh, let me just take a quick detour. One more thing about the PVP is that we do have an EHR plugin. This is just, these are some examples of the EHRs that we work with, but we've been working on how to have that be more integrated with your clinical workflows, and so you don't even need to leave your EHR for some of this information, including the care gaps, the referrals, and what we're going to talk about now, the risk adjustment factors. Okay, so RAF. What even is RAF? How can we address RAF gaps at the point of care? And what are some ways that you can keep an eye on what is happening with your population? So we pulled this slide. This is all centers in Kansas that use drives. Oh, excuse me. And in looking at this, I've blinded the names just to protect people who are doing pretty well or not so well. But is there an opportunity? And I believe there is. We have this center all the way over here on the right that's doing a pretty good job. And then all the way on the left, we have a center who has coded, maybe 12% of their RAF gaps. So again, this is a way to see how are we doing. We're about a little over a third of the way through the year. You'd expect that these would be rising pretty consistently. So in good shape across a lot of centers, and some centers do have some gaps. But what do we mean by RAF gaps and why are they important? So here is a graphic showing the 6 essential elements of value-based care. And today we're going to be talking about risk adjustment and stratification, but you can see all of the other things such as attribution or care gaps or patient engagement. But this is going to help set you up for success when it comes to your PMPM per member per month, and then that impacting directly your organization's bottom line. And this is all related to coding practices. And so again, to level set, what is risk adjustment? Why are we talking about this? It is a statistical process that considers the underlying health status and health spending of patients when examining their health outcomes or healthcare costs. And while there are numerous ways to risk adjust, we're going to talk about 2 specific ones. And why would we risk adjust? It's so that we can make sure that the contracts that our organization is participating in is going to compensate us fairly, that we're getting enough money for those complex patients. And we're also coding to specificity for, as many patients as possible to get as accurate of a reimbursement as we can. When we talk about RAF gaps, the first thing is, what is a RAF? And that simply is the risk adjustment factor. So these are individual factors that make up the risk score. And it helps to determine how the provider is reimbursed for the care they provide. And gaps are going to be when a code has been billed in the past, but not in the current year, then we're going to refer to it as a RAF gap. Do you need to recode everything that you've billed in the past? No, because sometimes conditions resolve or they're no longer relevant. So that's going to be up to the clinician at the point of care to determine if that is still a valid code or not. We have 2 primary ways we're risk adjusting in drives, and these are based on the Medicare hierarchical condition categories or the Medicaid chronic disability payment system. So they're designed for different populations. They have different policy goals. And the Medicare is obviously focusing on older adults, while Medicaid is focusing on children, pregnant women, people with disabilities, etc. Which one do we pick? So drives will look, is a patient on a roster? If they are, then it's going to use the plan mapping if it's mapped to Medicare or Medicaid. If they are not on a roster, it will use the UDS financial class to determine which payer. This green line here where you see Medicaid, dual, other, etc. So anyone who's Medicaid, dual, or they have other and they're under the age of 65, we're going to be using the chronic disability payment system to determine their RAF gaps, while anyone who is on Medicare or has other and is 65 or older, we're going to use the Medicare RAF gaps. And this is a little bit in the weeds, but we thought this was important to review. So what you're looking at is on the left side, you see coding from 2024. You had 5 categories documented by the PCP and the cardiologist for the same patient. And then on the on the right side, you see the coding for 2025 when the patient only saw the PCP. On the left side, there are 5 HCCs, and they each have a relative factor, meaning how many points basically do you get for having that condition. And the more specific the code is and the higher acuity, the more points it gets, generally speaking. So for 2024, the RAF score was 1.752. In a nutshell, that means this patient was going to be 1.7 times more risky or more costly than your average patient. And so for this particular year, you would have been reimbursed about $28,000 for taking care of this patient. However, in 2025, the patient only goes to see the PCP, and only 2 of the conditions are recoded. And in fact, the diabetes condition is not coded to the same specificity or complexity. And you can see that the risk factor points are about half of what they were. So for the following year, the patient's RAF score is 0.464, and the PCP is getting reimbursed $8,000. So way less than half, probably, less than a third of what they had gotten the prior year. Questions about how this works? Okay. And so the consequence of not coding accurately means you're possibly going to be leaving money on the table that you probably would need to care for your population. Okay, so how do you interpret this? Again, those RAF gaps will be surfaced on your PVP. We're going to look at that in a minute. And that's a suggestion to your clinical team. Hey, this was coded in the past. It hasn't been coded this year. Maybe you want to do that. If it's an applicable code, you can carry that over year to year. And also consider, you are able to make an independent clinical decision about recoding that and billing it again, or adding that to the next visit based on a referral that you want to do or lab tests. But again, the intent of the reporting is really to be accurate and maximize your reimbursement based on a clinically appropriate code. And I'll stop there for a moment if anyone wants to ask a question or ask me to review anything again. Okay, moving on. So this will all look familiar, so hopefully we can just blow right through this. We did review the fact that you now have RAF gaps on the PVP. And so here's a view of that. And during your huddle, or however you're using the PVP, again, you can add those, and the provider's then able to decide, do I want to bill this again? Do I want to defer? What am I going to do about this particular code? Prior, before the release of the last drives update, you could see the RAF gap disease groups, which is good information, but it wasn't really actionable. but now this has been built out to include those codes so that providers can take more focused action on closing those RAF gaps. What can you do with this information? So we have a couple measures and drives that could allow you to see, okay, what is going on with our RAF gaps? Are we doing a good job closing them? So this measure is called the HCC RAF gap closure. We're going to direct you to this one because there's many different ways to look at this, but HCC RAF gap closure is a good place to start. This measure will calculate the percentage of the HCC RAF gaps that were closed at the point of care or within 30 days after the kept appointment. And let's see. Yep, and the denominator is going to be that count of open HCC RAF gaps for the patient at the time of their kept appointment. So the patient has to have at least one open HCC RAF gap in order to qualify for the measure. This is another way you can look at this. If you are changing the comparison group to group by the provider rendering, this is a way you can look at provider performance. So perhaps there's a clinical or billing supervisor that might want to create some education or have some meetings with providers about the process for this and who's responsible, and keep an eye on how that is improving over time. You can also look at this by the RAF Medicare diagnosis category. So again, group by. And what that will show you is how are you doing in particular diagnostic categories. So what we can say about this particular graph is if we look at amputation, that's been closed at 50%. And I would say that amputations are probably permanent, usually, right? So that is actually something that could be coded year after year after year. We can see over here on the right side that injury doesn't have anything currently closed. And so that is injuries are some injuries are fleeting, right? They heal, and perhaps after a time they're no longer going to be a problem for that patient. And so that's something where you would not necessarily expect to have gaps being closed year after year. We also have a measure that is your recapture rate. And so this is going to be the count of RAF gap diagnoses that were billed in the prior calendar year and have been billed again in the current year. So that's another one to look at as well. And what is this data telling us? Again, some things that we have already talked about today. You can use this to specifically work with your providers on good coding practices. And again, you can look at this by the diagnosis categories and see, are there any categories where there's an opportunity for improvement? So I'll pause for a second. I hope I haven't confused you further. I hope this was helpful.
I don't see anything in chat yet.
Okay. All right. So what we'll do is I'm going to put Luann on the spot. We're going to talk about the risk algorithm. And I believe that your network has purchased this for you. It may be time to take another look at it and decide how you want to tune this up maybe, or change this if relevant, and what are some things you can do with risk within drives?
Perfect. Thanks, Hannah.
Yeah.
I'm gonna just look here. I'm gonna let you do this. So, you guys implemented risk a few years back. Oh man, it's probably been about 5 years, probably, because I think I did part of it with you all. And so would love to hear from you all in chat how you are currently using risk, right? And so, risk allows us to do a couple of things. And, I'll start by saying that this risk algorithm is, well, I'll explain it a little bit more in terms of how we count it, but it's weighted for different conditions. We provide a weighting, and those weightings that we provide are based on our experiences working with multiple health centers across the country and networks, and how they were rating things. And essentially, what it is most comparable to is the American Academy Family Practice, as well as what NAC puts together, which is a count of chronic conditions. And the goal here is around clinical care. So there's lots of chronic conditions in your populations. There are different behaviors that impact how well they perform in meeting their clinical outcomes. And for those patients who are not well managed, as you know, and even, compared to the risk stuff the RAF stuff that Hannah just talked about, those are the patients that then can cost you more because they end up in the emergency room. So we want you, and this network risk provides you with risk across all of your patients, not just risk associated with those that you get data from this plan or plan A or plan B or plan C. You can go to the next slide. And so what we're trying to do is capture for you, right, those patients who are most at risk of having negative outcomes, increased utilization, that might need additional support. And the risk algorithm is designed, this is, in the literature in terms of 5% of your population is driving the most cost, right? And so the highly complex are about 5%. The rising or moderate risk are about 15% of the population. And then everybody else is sort of in that prevention monitoring mode. So those are the ones that you're doing normal outreaches to remind them to do their immunizations or to get to meet certain criteria for if they have a single condition. The moderate risk is where you might have some impact, as well as in that highly complex group. And there are always a few in the highly complex that you're not going to be able to have impact on, right? It could have been, they might have been in an accident. They might be on a high cost drug. And why you can't see that all the time, this will help give you an indication of what those patients are. And I saw a comment come up there. Let me see so I can see it. If you have highly complex patients, but they are well controlled by their providers, their risk score will be lower, potentially. And I'll show you what I mean by that. So let's go to the next slide. And we'll get to where I can show you that a little bit better. Hold on here. Okay, so this is the Kansas risk algorithm. So this is actually, if you log into your EHR, if you log into Drives right now and go to the risk, you will see the same weightings on the left-hand side, because the left-hand side has the different risk criteria how we've weighted it. Thank you, Hannah. And you
Mhm.
can see, so for instance, across Kansas, diabetes, 30% of the, or 30, almost 30,000 patients have diabetes. That's a 14% prevalence across the state for the CHCs that are in drives. And 31% of those patients are considered high risk. And they are weighted at diabetes is weighted at 2 points. And so this screenshot shows you just the chronic conditions. I may ask Hannah, when you get a minute, not right this second, but when we get in the next one, if you log into Kansas, we can show them the other criteria which aren't on this screen. So this just yeah, so some of them are. So you get the diagnoses right now that are medical and also behavioral health. But down there, and I'll show you this in a minute. Let me explain the rest of this screenshot. So right there in the middle, you see the big pie chart, and the orange is your high risk, and that's actually about 7%. So overall of Kansas, there's 7% in the high risk, and then a little less than 15% in the moderate. When you log into your center, those percentages could be slightly different because at this level, the risk algorithm is applied across all the patients. And so right now there are almost 15,000 patients that are high risk out of 215,000 patients. Now, the way that what we do with those weightings is we add them all up on a patient. And when you slide over to or actually slide down to see the risk score distribution, Hannah, this shows you the curve of what patients' risk scores are. So you can see there's the 45,000 roughly that have 0, and then 1, 2, and so on, right? So the points get fewer patients have high risk scores, obviously. And then the way that we calculate this is we split it into the 3 categories of the older adult, the pediatric population, and the adult population. And so if you look here, what you will see is that I like to call them older than geriatric as I get closer to 65. You can see that the patients, you have about 18% that are in high risk, which is about 5,600 patients. And that means if they have a risk score of 17 or higher, they're in the high risk category. If they're 13 or higher, they're in a moderate risk. Now we adjust those thresholds for the adult and the pediatric population. So, and that's because the older you are, the more likely you are to have more chronic conditions, and we're trying to distribute that across the population. Some organizations may choose not to differentiate that between the older adult and the adult population. You definitely have to do it for the pediatric population, because otherwise you would not have you would not capture any peds patients in your algorithm because they don't have as many chronic conditions as adults. And so you can see for them, the threshold is 9. And so one of the things that Hannah alluded to earlier is that we may want to adjust some of these pieces, and we can look more closely at the criteria in your risk algorithm and how things are weighted. Yours is pretty up to date, I would say, probably with the exception of the staging for kidney disease. And then down below this, the other really important piece that people could use, and again, I'm curious if there's anyone out there that is, and how you're using the risk, but you can see this also shows the rising risk patients. So these are the patients who were low or moderate risk, and all of a sudden went into the high risk category since their last visit. right? And so those are ones that you might be able to find early. It could be things that got diagnosed since the last time they were here by a specialist and got added to the problem list or assessments that we're capturing. Or they, could have just been on that edge the whole time. So let's go to the next slide. So this, I'll show you a little bit about the rising risk. So this is if we can drill into that widget just like you can on other dashboards, right? And you can see that this is not the Kansas population, it's another example, but you can look at rising risk by risk score. You can look at it by provider or location. At the network level, you can look at it by center. I mean, this is mostly used at the center level. So these are good patients that you might want to have a care manager or a care coordinator, depending on how your system is set up, look at and see what they need. And Heather, are we going until 1 or 1:30?
I think it's just till 1.
I think it is,
Okay.
yeah, 1
Okay,
hour.
cool. That's what I just making sure. So let's go to the next slide. And this shows you the different components that are in the risk algorithm. So the question earlier about if you are well controlled, will your score be lower? And the answer to that is to a degree, because your diabetes probably didn't go away or your hypertension did not go away. But one of the categories that we have is clinical outcome indicators. So we look at your cholesterol. Your blood pressure is included in your ASCVD risk score. Your PHQ-9 is there, A1C. So if you have not had an A1C, you may get 3, you may have a weighting of 2 or 3 points versus an A1C that's 9 to 10 versus 10 to 11. So the better controlled your A1C level or your blood pressure, it could impact the score in your risk algorithm. And the same for kidney failure. We also include things around SDOH, around medications, and around utilization. There's missed appointments. There's also, we are able, for those who do capture well inpatient visits in their EHR, we are sometimes able to map those. So let me see where we want to go. I just want to, let's skip ahead, Hannah, I want to go to the slides that show the risk registry, a few down, and just show you. One of the nice things about risk, again, it's across all your patients, whether they're insured or uninsured, and looking at them by the clinical information you have in their EHR. All the patients that show up on that, because you can't drill into all the numbers on the risk dashboard, but there is a risk registry. It will either be called risk registry, it may be the Kansas risk registry or CCNK. And you can see each individual patient here and the different things that put them in the risk category. You can apply filters, and there is a risk filter on almost every measure. So you can look at hypertension by your high, moderate, and low risk patients. And I could filter this to high risk for one usual provider and be able to look at those patients specifically. This is also on, I think the next slide is the PV. Well, this shows the filtering. Let's go to the next one, which is the PVP. So you can see the risk up there in the blue header. And on the patient visit plan, on the care management passport, you can see the specific things that make up that risk. So you can look at it in the registry, but this is a nice succinct way to see what things scored this patient higher. For those who want to see that quickly, and you should be able in the risk registry just to right click and go to the CMP, and you'll be able to see that information summarized for you. So I know we don't have time right now, but I want to stop in case there's questions. And we would be interested, and you can let Heather and Maria know this afterwards. You know, how are you using it? What are the things that you're struggling with on it? In these slides, you will also, if you are doing any work around panel management and understanding the different providers' workload and what the composition of their panels are. And you can go to that slide. It might be one of the next ones. So there's the panel size measure, and you can see by provider. But if you go to the next slide that Hannah has for you,
There we go.
you can see for each provider, out of their total panel, how many are high, moderate, and low risk. So the orange is the high risk. And this is demo data, right? So when I look at this one, nothing really pops out at me, right? Except for maybe that provider right to the right of center who's got a slightly smaller group of high-risk patients. But they're all around the same size panel, and the distribution is fairly similar. When you get your part-time providers versus your full-time providers, you may notice some differences in this, and it can help as you're trying to balance out workload. And I'm going to stop there in case there's any other questions.
I don't see any questions, but we do have our evaluation in the chat. If you have any follow-up comments, please go ahead and put them in the evaluation. And then our next Azara training in 2 months will be more on panel management. If anybody has any questions, please go ahead and come off of mute or put them in the chat. I am keeping an eye on the chat, but I haven't seen any questions come across.
And I'm going to drop because I have another presentation that I have to do at 1, but Hannah can answer any questions, or if not, find out that answer. Thank you.
Thank you, Luann.
Thank you, Luann. Yeah, so I can hang on for another minute or two just in case there are any questions. But again, thank you so much for having us today. We appreciate the opportunity to present some of these new features in Drives, as well as review the RAF gaps and the risk algorithm with you.
Thank you.
Thanks, everyone.
Thank you, everybody. Please do the evaluation.